Okay, let's get started. Welcome to week 6 of the Sagis Dermpath Happy Hour. My name is Dr. Keagan Lee. I'm actually one of the co-founders of Sagis. And for those of you who are new to the session and have not had a chance to check us out on our website, we are a dermatopathology lab in Houston, Texas. And we have offices around Texas in Dallas, San Antonio, and Austin. I am actually in our Austin office right now. So wanted to welcome you guys. If this is your first time, just want to make sure that you guys got the slides ahead of time. If you did not, please either check your junk mail if you did register, or if you provided us an institution email, it may be that the slides are being, or the emails being rejected by your institution email. So try to provide us with some other email like a Gmail or a Hotmail, and you can email us that email address at education@sagis, which is SAGIS.com. And it's really important for you guys to get the slides ahead of time and try to look at them yourself, come up with your own thoughts on it, and you'll get a lot more out of these sessions if you do that. Also wanted to let you guys know that next week we will not have a session because of the holiday weekend. So we will resume the following week after that. So enjoy your weekend. And lastly, for graduating residents and second-year residents who are going to be taking the core exam, we have a board review coming up we have 2 sessions that you can sign up for, May 30th and June 6th. Technically, the deadline has already passed, but we will accept some late registration. So again, if you're interested in that, go to our website, sagisdx.com, and click on the education tab, and you can register that way. You can also email us, and we will send you the 80 virtual digital slide deck that we will be going over for the review session. And just a couple of some cool numbers. We started this about 6 weeks ago, and we're really excited and happy about how many people have found this useful and have signed up. We have just in 6 weeks, we've gotten people from over 70 U.S. dermatology residency programs, that from 30 different states. We've also got programs from around the world, including Canada, Mexico, South Africa, India, Saudi Arabia. I think we just got someone from Hong Kong. So welcome, everyone. Really happy you guys are enjoying this. Please give us your feedback. We're always trying to make this better. And with that, I'll go ahead and get started so we can get going on these. Again, if you did not view these, try to get access to the slides ahead of time and look at them so that you come up with your own thoughts before watching this. Okay, the first one, hopefully everyone can see my screen and can hear me. I do have my chat up. Yesterday did not. Can you hear me now? I've gotten some people saying they can't hear. If someone will just let me know that they can hear, I just want to make sure. Okay, great. I have someone responding yes. Okay, cool. This is live, so this is not edited. So let's go. I will check the chat from time to time if you have any questions, see if you, and try to address those as we go. Okay. All right, first one. As with any slide, if you're looking at digital slides or glass slides in pathology, we always look at things low power. So try to span the whole biopsy first and get our thoughts, and then we zoom in on higher power. So here's the first one, and we have the epidermis. The overlying epidermis, start from top to bottom. The epidermis looks relatively normal. It might be a little bit hyperplastic. Reedy ridges look intact. So the normal architecture of the epidermis is intact, and there may be a little bit of overlying orthokeratosis, but otherwise the epidermis looks somewhat relatively normal. We have a superficial perivascular inflammatory infiltrate. As you can see, it's mostly in the upper dermis. Don't know what those cells are yet. And I'm going to go ahead and zoom in at this point to get a little bit closer. All right. Hopefully that's clear to everyone. Again, a perivascular inflammatory infiltrate. And what you'll start to notice, if you look in the papillary dermis, there's a lot of pink wispy stuff. That is fluid. That's edema in the papillary dermis. There are also tiny inflammatory cells within that edema as well. As you can tell, this pink stuff is not collagen. As you can see in the underlying dermis, the collagen are kind of wispy, ropey, has a wispy, ropey structure. This fluid is a little bit more pink and pale, and it doesn't have that same structure as the collagen. If we go in a little bit closer, let me take off look at the inflammatory cells, mostly lymphocytes. Okay, I don't see a lot of eosinophils or neutrophils. Underneath the papillary edema, there are a few neutrophils, but those may be due to disruption of the dermal epidermal junction. Whenever you get disruption of that, you can have, like in an ulcer or something, that you can have underlying neutrophils, but mostly this is lymphocytic. Okay, so let's zoom back out. Let's look over here where there is not papillary edema, where the dermal epidermal junction is intact. And the basement membrane over here does not look thickened. I cannot see a prominent basement membrane here. Okay, so there's no thickening of the basement membrane. So taking it all together, epidermis is relatively normal. Superficial perivascular, predominantly lymphocytic infiltrate, and prominent edema of the papillary dermis. This is polymorphous light eruption. Okay, the reason I was looking over here at the basement membrane is I was trying to see if it was thickened. If it were, you would start thinking of lupus, discoid lupus, and bullous lupus can have a similar picture as this, but it will often not have this much papillary edema. When it's bullous, you just have a kind of some separation of the dermal epidermal junction. I also don't see a lot of vacuolar alteration here, and you would expect to see that in some vacuolar alteration in lupus. So polymorphous light eruption. All right, let's go to the next case. Again, we're at low power here. And right away, this is kind of there's a bunch of things going on here. There's 3 pieces of tissue, okay? Each piece has some different things going on. Right away though, my eye kind of goes to this piece. Something's going on over here. There's also, let's look at this piece first though, because I want to point this out. So up here, this is bone. Okay, for those of you who haven't seen bone before, this is a piece of bone, and this is bone marrow in here. Okay, it's difficult to tell if this is metaplastic bone or this is just underlying bone from the biopsy. They went real deep and shelled some bone. Difficult to tell there. So I just wanted to point that out. It's not actually relevant to this, to the diagnosis here, but let's go in here at this piece. And this is what caught my eye when I was first looking at this on low power. You have this kind of cystic structure with lined by squamous, stratified squamous epithelium. Okay. Strongly resembles the epidermis. It's somewhat papillated. And from the cystic structure, you have pilosebaceous units emanating from it. You also, let's see here, you also have some eccrine units, and you might even be able to get some bundles of smooth muscle. What I don't see around the lining is bone or cartilage. We did have that big, huge piece of bone in the other piece, but I don't see it in the lining around this cystic structure. So this is a cyst, and because it has these pilosebaceous units around it, this is a dermoid cyst. If you saw cartilage and bone, you would think of a cystic teratoma, but I don't see that here. And so some of you might have thought this is that this could be a steatocystoma because of the sebaceous glands around it. But this actually has follicular structures as well, which would be somewhat unusual in a steatocystoma. Also, a steatocystoma does not have, if you look at the contents of the cyst, it does not usually have these cornified cells. Okay, it usually has sebum in the cyst, which clears out in processing. So you would have a cleared out space here in the cyst. And also the lining of a steatocystoma, you have a really, really prominent eosinophilic cuticle, a really thick cuticle that we do not have here. Okay, so this is not a steatocystoma, this is a dermoid cyst. Next case, I'm going to go ahead and flip this here so it's a little bit better oriented. Okay, we can focus on either piece here. The features are very similar. This is a somewhat, if you look at here, you can see this lesion is somewhat well circumscribed. Okay, I think I can draw this here. It's kind of a papular structure or papular configuration to this lesion. You have all of these little basaloid, they're blue aggregates, and then you can also make out all these little cystic structures within this as well. Let's zoom in a little bit further. The overlying epidermis is a little bit thinned because this appears to be pushing up into it, but I don't see any of the structures really touching or coming off of the epidermis. So most of these structures appear to be completely in the dermis. Zoom in a little bit more. Okay, again, now we get a better look at these basaloid aggregates. You can see the tiny little cystic structures, and they do have what looks like some material cornified cells maybe within them. Okay, you guys can see that. Notice the stroma on this, the surrounding stroma within this lesion. So if you go to the very edge, you can make out some of the residual collagen here. Okay, maybe at the other edge we get a little bit more. Over here, this collagen right here. But look at, within the lesion, look at this stroma here. It's a fibrotic stroma with a proliferation of small fibrocytes. Okay, so we've got this kind of fibrous stroma within this lesion. I'm not seeing a lot of mucin. Okay, if there is any, it's very minimal. So I don't see mucin within the stroma, so it's not a mucinous stroma. It's more of a fibrous stroma. If you look around at these basaloid aggregates, there is some focal clefting, okay? But most of these do not have clefts. If anything, you have cracks or clefts within the stroma, but you don't have a lot of separation of the basaloid aggregates away from the fibrous stroma. So the clefting is extremely focal. And in addition to that, if you look around, you can see this lesion trying to make little primitive follicular structures. Let's see if we can find a good one here. Let me zoom out a little bit. Okay, there we go. So here's one, it's trying to make one. Here's another one where this, you notice this here where you have the basaloid aggregate, and then with around it, you have these little tiny cells within the stroma. They're kind of forming a little ball. This is, we call this mesenchymal, papillary mesenchymal bodies, because this is like little mesenchymal cells. See if we can find a couple others. There are several of them in here. Oh, I saw a couple here. Here you go again. This is one right here. You guys see those? Here's one without where the epithelium just didn't show up around it. Okay, so these are papillary mesenchymal bodies. So when you put all this together, basaloid, a proliferation of basaloid cells with these little cystic structures and a fibrous stroma with papillary mesenchymal bodies, this is a trichoepithelioma. Okay, and I tried to point out some differences. Some of you might have thought this was a basal cell carcinoma, which is definitely in the histologic differential diagnosis. So some of you might have thought this was maybe a infundibulocystic basal cell carcinoma, and it can be tough to distinguish those. But I wanted to point out some of the differences. You shouldn't see papillary mesenchymal bodies, or at least this many in a basal cell carcinoma. Also, I tried to point out at the very beginning, when you zoom out, this thing has somewhat of a well-circumscribed look to it, okay? Very round at the edges. You can kind of make out the edges here. And along with the stroma, the fibrous stroma, it's not a mucinous stroma. In basal cell carcinoma, you tend to get mucinous stroma, especially around the basaloid aggregates. We don't have that here, okay? And it's actually the mucin that is what causes the clefting in between the basal cell carcinoma and the surrounding stroma. So when you go and look at those clefts, you can actually see some of the mucin in the cleft oftentimes. So if you're in doubt, go and look for that. We do not have that here. We do not have the mucin here. So this is a trichoepithelioma. I got a question about how to tell between a trichoepithelioma, the difference between trichoepithelioma and trichoblastoma and basal cell carcinoma. So trichoblastoma is just kind of a subtype of a trichoepithelioma. It has a little bit less differentiation towards follicular structures, so you often don't see papillary mesenchymal bodies. But again, the stroma should be the same. Should be this fibrous stroma, should be relatively well circumscribed. And one last feature that I did not point out here is that if you look around in these cells, you do not see necrosis, either necrosis, vast zones of necrosis, or individual necrotic cells. And you often see that in basal cell carcinoma. Okay, so that can help you with trichoblastoma too, trichoblastoma versus basal cell carcinoma. So really look at the stroma, guys. That helps tremendously when you're trying to look at this. But also on low power, just look to see if it looks somewhat well circumscribed. Basal cell carcinomas can be well circumscribed, but trichoepitheliomas are certainly almost always well circumscribed. Okay. Next case. Reorient this for you. Look at this at low power. Right away, I can tell that the epidermis is not normal. We've got these big cystic spaces in the epidermis. Looks like we might even have some edema, papillary edema, or at least some fluid or separation in the subepidermal space. Okay. I also noticed that we have perivascular inflammation. If you start to, your eye will start catching this pattern. And you see you can tell this is going around blood vessels. This kind of arborizing pattern. That's what the blood vessels do in the dermis, and so this inflammation is following that. Okay, so perivascular inflammation, mostly in the upper dermis, but some in the mid dermis and maybe even slightly in the deep dermis, but mostly superficial perivascular inflammation. Okay, let's go in a little bit closer. All right, again, you could see these cystic spaces here in the epidermis. And they also have some inflammatory cells, or some cells within them, and we'll soon see those are inflammatory cells. If we look at the perivascular inflammation, we start to see eosinophils. And I know it doesn't show up great on these digital slides, but you can see this very red cytoplasm. Those are eosinophils. Okay, so all these smaller dark cells are lymphocytes, a few eosinophils, and then within the cystic spaces within the epidermis, you also have eosinophils. And if you guys can see that, a lot of these cells are eosinophils. Where you don't have the cystic space, let's look at the epidermis. You do have some spongiosis where you can start to see some separation between cells. That's due to fluid and edema. So that's spongiosis. All right, look over here too. It's even more prominent in this area. The cells are starting to split apart, and this is probably eventually going to form a vesicle. So spongiosis. And when you get a lot of spongiosis, you start to form vesicles. And this vesicles, look at it's trying to spill out its contents onto the surface. And that clinically will give you a very wet look to the lesion. So we've got a spongiotic dermatitis here with eosinophils. And you have the eosinophils in the epidermis. I think I got one here. You can actually see an eosinophil in the epidermis and within the cystic vesicles. So this is a spongiotic dermatitis, and this one happens to be allergic contact dermatitis. Really, it's impossible to tell just on histologic features alone what kind of a spongiotic dermatitis it is, but the fact that you have eosinophils in the epidermis can kind of help you lean towards a contact dermatitis. Spongiotic drug eruption would look very similar. Even really, really florid eczema or an id reaction could look like this. So really, you're in the spongiotic dermatitis category, but this one happens to be contact dermatitis. It is not irritant contact dermatitis. That also shows spongiotic dermatitis, but in addition to spongiotic dermatitis, you get necrosis of the superficial layers of the epidermis, and we do not have that here. Okay. You often also get neutrophils because of that irritation, that surface irritation and necrosis. You'll get accompanying neutrophils, and I did not see that in this slide either. So spongiotic dermatitis, and this one happens to be allergic contact dermatitis. All right, next case. I'm not seeing any questions over here, so keep moving. Again, low power. We have something going on in the superficial dermis. It seems to be somewhat well focused and in a well-defined focus. So I'm going to zoom in on a little bit further. The overlying epidermis seems to be relatively normal. Let's go in here. And as we get a little bit closer, we can see brown pigment. Okay. Whenever you have brown pigment, it's either melanin or hemosiderin. Hemosiderin tends to be a little bit more orange in color. This one seems to be just straight brown, so I'm favoring melanin pigment. And then you have all of these small cells, those are lymphocytes, so you have a lot of inflammation here. But mixed in within the inflammation, you have some larger cells. Your eye starts to catch these larger cells, okay? Some of you might be thinking, okay, those are histiocytes, but if you look away from the inflammation, you can start to see that these are forming, they start to form some nests and cords, okay? And when you put it together with the melanin pigment, these are melanocytes. And you can see smaller nests in the upper dermis up here, or nests of melanocytes. And as you go down, the cells start to get slightly smaller. The melanocytes get a little slightly smaller, and you start to get more cords of cells. So this is a intradermal nevus, and it's very, very inflamed. So that's what was making it very hard to tell what it was at the beginning. It's very inflamed, and this happens to be a halo nevus. Okay, it's really just an inflamed intradermal nevus. Clinically, it can have a halo. It doesn't always have to, but we call these halo nevi, inflamed intradermal nevi. Okay, why is it not melanoma? Well, the melanocytes are relatively small. They mature from the top to the bottom. It's in a relatively well-defined focus, and I'm not seeing any atypical proliferation in the overlying epidermis either. So this is a very relatively small lesion, in a well-defined focus that matures, so it's benign, it's a nevus. All right. Next case. All right, there's two things going on. Probably what was biopsied, which is, as you can see, the epidermis over here is a little bit hyperplastic, somewhat papillated with overlying hyperkeratosis. If we go in and zoom in on that very quickly, the keratinocytes do not appear, they do not appear atypical. So that just looks like a benign seborrheic keratosis. But look at what's going on in the underlying dermis. There is this dark black pigment. And if you compare that to our previous one, which was more brown pigment, that you can see how black this pigment is. It sticks out very, very prominently. And it tends to be perivascular. Again, remember that arborizing kind of pattern? This pigment is aggregating around blood vessels. There is some in the interstitial areas in between collagen bundles, but most of it is around blood vessels. Let's go take a look at that pigment a little bit more closely. Again, very dark, coarse, clumpy pigment around these small blood vessels. And I don't see any brown areas. So this is tattoo pigment. Okay. Why is it not melanin? Well, one, because of the color. Two, the pattern. Okay. Melanin pigment tends to be, first of all, in the upper dermis, like if you had a post-inflammatory changes, those will be in mostly in the upper dermis, and it's a lighter brown color. does not tend to aggregate like this around blood vessels. So this is not a blue nevus. Other things, if you're thinking minocycline hyperpigmentation, that's a good thought. Again, that tends to be more in the upper dermis, and you would also be able to do stains for that. It should be Fontana Masson positive and pearl iron stain positive, but tattoo pigment will not stain positive with those stains. What else can I tell you? You can notice that this is kind of from side to side. It's very broad, so it has no real configuration. It's just mostly perivascular and a little bit interstitial, and that's what you see in tattoo pigment. All right. The last thing, if you go in and just zoom in, most of this is kind of free floating, meaning it's not inside of a cell like a histiocyte. A lot of times with melanin pigment, you will see it either within an actual melanocyte, dendritic cell, or a histiocyte, like a macrophage. And here we don't see that. I know it's very hard, kind of hard to tell, but you should be able to look around and at least find a couple of cells that would have the pigment in them, and it's very hard to find that here. Okay. Let's go to the next case. All right, it's a very small biopsy. The epidermis looks relatively normal. I don't see a lot of inflammation in the underlying dermis, even though we're very superficial here. Okay, so I'm not seeing too much going on. Maybe a little bit of spongiosis in between cells, but really, if you're having trouble figuring out what's going on, always zoom in even closer. And as we zoom in closer, you can see something going on in the cornified layer. You see all these little tiny, kind of more basophilic blue structures in the cornified layer. No, it's very hard to make out what. This is what Tinea versicolor looks like. So this is all fungus. Okay, and for Tinea versicolor, you can make that out on H&E pretty easily. For other types of dermatophytes, you need a PAS stain to really visualize them. But with Tinea versicolor, you should be able to see them on H&E. So Tinea versicolor, not much more to that. Oftentimes there's not much inflammation. You can have a little bit of spongiosis, but there's usually not too much accompanying inflammation with that, with Tinea versicolor. Okay, next case. All right, we have a shave biopsy, and the overlying epidermis looks relatively normal. It might be a little bit thinned. You see that? Oh, it's kind of lost the reedy ridges here in the central part. And beneath that, notice how the underlying dermis is just kind of washed out, very pale. Okay, over here to the sides at the edges, you can see that it's much more pink, which is what normal, the normal dermis looks like with the normal collagen. And in this area, it's just very, very, in the central part, it's just very, very pale. Okay, notice how that pale area is in a relatively well-defined focus. Okay, it's not throughout the dermis from side to side. It's just in this central area. Let's zoom in. You have blood vessels in this. Okay, so you've retained the blood vessels, but notice you can see the residual collagen bundles. Okay, those are all separated by this pale, washed out area. This is what focal mucinosis looks like. Digital mucus cyst is basically the same thing, just on the fingers or toes. This is focal mucinosis. This slide is a little bit pale, But mucin has a bluish tint to it on H&E. This slide is lacking a little bit in the H, so it's not, doesn't have the basophilic side to it. So if you wanted to confirm this, you could do it with stains, and you can do stains that would highlight the mucin, so colloidal iron or Alcian blue. Those are two stains you could do. And those stains would really highlight the mucin and be this very dark blue, blue color, pretty blue color. So I wanted to point out that this was very focal, so that's what gives its name, focal mucinosis. In other cutaneous mucinoses, like myxedema, just cutaneous myxoid conditions, you would have more diffuse mucinosis. It would not be usually this prominent, this pale, so it'd be a little more subtle to where you would sometimes need to do stains to better visualize it. With focal mucinosis, it sticks out. It's right there, prominent, right, usually right in the middle. It tends to push up and push up the lesion so that the lesion is papular, and it will often thin out the overlying epidermis because it's pushing up so much. So focal mucinosis. All right, just a few more here. Okay, this is a very large biopsy. We'll start from top to bottom. The overlying epidermis looks hyperplastic in some areas, more normal in other areas. Okay, notice how thick the dermis is, and it's thickened by what looks like a lot of inflammation. Okay, and then at the in the deep portion of the dermis, it looks like it's very fibrotic, and the fibrosis is actually extending and widening some of the septa in between the fat lobules down here. But you also notice from low power, you see all these structures here, these little cystic structures. Okay, if you can imagine, you see the epidermis and you see how this squamous epithelium is kind of budding down. You can imagine that this might all be kind of connected, might be kind of interweaving. And so just in this plane of section, you're not getting the entire structure, but this is a sinus tract that's lined by squamous epithelium. So we've got this sinus tract structure. Some of you might have thought that this could be this could be squamous cell carcinoma, but again, that's a good thought. Squamous cell carcinoma, one, you would have a lot more connection here. It wouldn't track sideways. That would be very unusual. This one's tracking sideways. And then if you had any doubt, go in and look at the cells, and there shouldn't be that much atypia. And in this there isn't, okay? There's really not much atypia to these keratinocytes lining this squamous epithelium. Notice all the inflammation. If you zoom in, it's a inflammatory infiltrate. You've got everybody here, lymphocytes, plasma cells, histiocytes, and then tons of neutrophils. In certain areas, it's almost forming little micro abscesses. So you put it all together, sinus tracts, fibrosis, dense inflammatory infiltrate with lots of neutrophils. This is hidradenitis suppurativa. You'd want to oftentimes rule out infection as well. So you can do stains for with PAS, Gram, but you shouldn't find any organisms in this. And hidradenitis suppurativa goes through phases. So depending on what phase you biopsy it in, you're going to see different features. This is kind of an intermediate chronic phase. So you got lots of fibrosis, fibrous tracts. In the very early phases, it's a very suppurative folliculitis type look to it, but just very florid. So, but once you get to this phase, this is what you see in the later stages of hidradenitis suppurativa. Okay. one. Here we have a punch biopsy. Okay. Oh, sorry, I didn't mean to zoom in that much. All right. The staining is, again, a little pale, so sorry about that, but you have the overlying epidermis, looks relatively normal. The underlying dermis might have a little bit of inflammation, but you see this is all subcutaneous fat, okay? And the fat does not look healthy. There's a lot going on here in the fat. So if we zoom in, that's where most of the action is going on here. Focus in on the fat. You notice that normal fat has very thin cell wall. Adipocytes have very thin cell walls. Okay, but in this, you can actually see the thickened cell walls. You can even start to see some fibrosis, and you see inflammatory cells in between the adipocytes. In other areas, you have multinucleated histiocytes. You guys see those? Multinucleated histiocytes. And then you have these needle-like clefts in some of the histiocytes, and they kind of radiate. This is what you see. Here's another one right here, these needle-like clefts, okay? So you're starting to get fat necrosis with this kind of granulomatous inflammatory response to it. This is what you see in subcutaneous fat necrosis of the newborn. All right, clinical information to help you here to know that this was a newborn or an infant. But the features, once you notice that something's going on with the fat and that there's fat necrosis, it's all these radiating needle-like clefts that really clue you in. Okay, there's also this mixed inflammatory infiltrate that accompanies it. But those structures, that's what you see in subcutaneous fat necrosis of the newborn. All right, so look around, look for those. Okay, we're moving right along, just a couple more. All right. We've got this shaved biopsy here. Overlying epidermis looks a little bit hyperplastic. It's maybe even ulcerated here focally, you see that. Okay. And then you've got a lot going on in the underlying dermis. Very busy, lots of cells in here. So let's go in and look at that. All right. From this power, you can actually see some multinucleated histiocytes. You guys see those, multinucleated histiocytes. Some of these histiocytes are not multinucleated, but they're trying to form aggregates. So I've got some granulomatous inflammation here. There's also lymphocytes and maybe some plasma cells in here. But look at all these cleared vacuolar spaces. Let's look at those. When we zoom in even closer, you start to make out little tiny dots in these vacuolar spaces. These are actually histiocytes that are being distended, okay? And they're being distended by these little tiny dark organisms, okay? You can notice how small those dots are compared to the nuclei, the surrounding cells' nuclei. This is Leishmania. Now, Leishmania has a very similar appearance histologically to histoplasmosis. So if you want to discern the difference between those two, one, you can look at histoplasmosis will often fill up the entire cell, but so can Leishmania. If you look around, you can see that, yeah, it's kind of, Leishmania tends to be more at the periphery, but you can do stains. And so, excuse me, because histoplasmosis is a fungus, it will stain positive for PAS and GMS. Leishmania is going to be positive. It's going to be negative for GMS. Can kind of, in my experience, I've seen it positive for PAS as well, but on the boards, I'd probably say it's PAS negative. And GIMSA is the stain that is kind of the gold standard. In practical, everyday Dermpath practice, I found that GIMSA is not a very helpful stain. It is helpful. It's very nice stain on cytology preps, but on on skin biopsies, it's very hard to make out the organisms. So really, once you can show that there are GMS negative, you're dealing with Leishmania. Okay. All right. Thank you for sticking around. Okay, this one will be very quick. We have either an incisional biopsy or punch biopsy. The overlying epidermis is a little bit hyperplastic and papillated. And centrally, you have this pilosebaceous unit. And then around the pilosebaceous unit, you have all these pink bundles of smooth muscle. Look at all those. You have a ton of smooth muscle. Smooth muscle, you have a lot of smooth muscle in two areas of the body, in the genitalia, like the scrotum, or around the nipple. Okay, and so you have all this smooth muscle. You have this kind of papillated epidermis, and then look at this. You have this glandular structure with apocrine epithelium. Okay, that's what you see in breast. So this is an accessory nipple. I mean, this could be a normal nipple too, but this is an accessory nipple. This is a Montgomery tubercle. Okay? It's just a kind of a sebaceous, pilosebaceous unit with prominent sebaceous glands. And then you have your apocrine or your mammary gland epithelium. Okay. If some of you might have just thought this was like sebaceous hyperplasia, but look around. Oftentimes you don't get the mammary, the breast glandular structures, but the smooth muscle is really, really always going to be there and it's going to tip you off. If you look in this area over here, you can actually still see the smooth muscle bundles. Look at all of those. Okay, that's what should tip you off to this being accessory nipple. All right. Are there any questions you can ask on the chat? I don't see any. You can always email me directly if you have any questions. My email address is klee@sagisdx.com. You can also email the education@sagisdx.com email as well. Hope you found this very useful. And again, if you have any questions, just let me know. We will skip next week and we'll see you guys the following week. Thanks for joining.